All right, Allison, we're on.
All right. Hello, everybody, and welcome to our JH-WICY Partnership for Excellence in Care webinar toolkit virtual series. While people log in, I'm just going to start talking because I'm hoping this is going to be an interactive and great session today. So just quickly about JH-WICY as people log in. Our vision really is to achieve a more coordinated response to HIV care by establishing mutually beneficial relationships that increase the quality of care that we provide as a community. To make sure everybody knows what WICY stands for, so women, infants, children, and youth. That's a population that we as a program address. And the mission really is to build upon existing structures and systems that we already have to create a dedicated network of providers that take care of this population and really think about coordinating on multidisciplinary systems of care. Can't speak today. The goal of this toolkit virtual series is to engage and amplify. We're going to talk today, and it's one program, but the goal is to have every program weigh in, bring what they have, and amplify your voices too. And so, it's really my pleasure to introduce our speaker today, which I'll hold off for a second. Next slide. For those of you who don't know me, I'm Allison Agwu. I'm a professor of pediatric and adult infectious diseases here at Hopkins, and I happen to be the PI for the Part D Wiki program, as well as the program director at the IPC program and ACE program. Today, we're going to talk about quality improvement, but just to highlight what we have coming next, unique aspects of care for LGBTQ youth by Renata Ironton Sanders, who runs our Emerge program and is an adult and pediatric adolescent provider. And today, it's my pleasure to introduce Megan Armbruster. Megan is fantastic. She is an RN BSN, clinical nurse and medical case manager in our intensive primary care pediatric adolescent HIV/AIDS program. Megan graduated from Johns Hopkins nursing in 2013, then worked on the POLK unit, the inpatient HIV unit here at Johns Hopkins, and then went on to the Timothy School, where she was the director of health and wellness at the Timothy School. She brought all of that experience to us in 2019 when she came on as our nurse case manager, and really has been not just fantastic with our patients and populations, but really instrumental in developing and implementing quality improvement initiatives to optimize our outcomes for our population in the program. Aside from her wonderful smile and her amazing energy, she loves to run, read, travel, and she's a tireless advocate for our youth and our population. So with that, I'm going to stop talking and defer to Megan, who I truly said I am just window dressing for her. She can run with it. And then to highlight, also we have other experts in the field, Marina Steraforte, our Part D folks, Iris and Jennifer, who really have taken the lead on this as well. Take it away, Megan.
Thank you. Thanks, Dr. Agwu, for that intro. And I'm excited to be here today. I'm going to share my screen and pull up the presentation that I have for you all today. So let's see. Okay, let me just move this. So today I'm going to be presenting on optimizing quality improvement in HIV clinical programs. So we are not experts in QI here, but we wanted to share with you some of the experiences that we've had with engaging in QI projects. And then to hear from you all too about things that have worked, things that have been challenging, and to get feedback and ideas. So I'm presenting with Dr. Agwu. And then as Dr. Agwu mentioned, I'm the IPC nurse case manager here at the Harriet Lane Clinic at Johns Hopkins. So the objectives for today's presentation are to review the concept of quality improvement, highlight ways to identify, address, and sustain quality improvement initiatives in the context of HIV using experiences that we've had with developing QI initiatives, and then to discuss mechanisms to share QI outcomes to influence clinical practices, best practices. So I wanted to share a little bit about the IPC clinic, which also stands for the Intensive Primary Care Clinic. Our mission is threefold. One is to provide HIV primary care to assure the best quality of life and health outcomes for infants, children, adolescents, and young adults living with HIV across the life course by providing state-of-the-art, evidence-based, culturally sensitive, coordinated, and comprehensive patient and family-centered HIV primary care. and then to link and engage patients to provide access to early identification of HIV infection to get them engaged in care as soon as possible and link them to care. And then treatment and prevention as well. So to improve treatment and prevention strategies for HIV and its complications through clinical research. The clinic was started in 1985 by Dr. Nancy Hutton, who's pictured here, who retired last year. She started the clinic here at the Harriet Lane Clinic and started the clinic as a solo practice, and it grew to a one-stop shop model. So back in 1985, youth who got an HIV diagnosis had a very different prognosis than today and would often get extremely sick. So hence the name of the clinic, Intensive Primary Care Clinic. So over the years, there have been many changes to medication and to HIV care, even within the last 10 years. And so the prognosis is totally different than it was in 1985, but our patients continue to experience and face unique challenges that we're here to address and to continue to improve the way that we address and meet their needs to improve health outcomes and reduce barriers. And the way that we really do that is through quality improvement initiatives. So throughout the years, there have been many QI projects that have grown this clinic from a solo practice into the one-stop shop model that we have today. The directors of our program are Dr. Agwu and then Dr. Renata Arrington Sanders. And then our program coordinator was Nancy Campbell, who is fabulous. She left several weeks ago, but she was here for 17 years and has tons of knowledge that she's been able to share and helped initiate a lot of the QI projects that I'm going to talk about today. So as I mentioned, we serve infants, children, adolescents, and young adults, birth to 25 years old, living with HIV. We serve adolescents and young adults, birth to 25 years old, who are at risk for HIV. And a lot of that is done through our adolescent clinic here at Harriet Lane. We have an amazing PrEP program and HIV testing program. So we're able to link and engage patients into care if they do have a positive diagnosis very early on. We also see HIV exposed infants up to the age of 2. Marianne Grasso is our nurse practitioner, and she's fabulous and amazing and sees infants up to age 2. And she'll also continue to see our young adult moms along with their children. So that helps reduce barriers to care because moms are able to, families are able to reduce the number of appointments that they have. And this came about through QI initiatives. And then Marianne and Dr. Agwu are also involved in developing safe breastfeeding guidelines to help support mothers who are living with HIV who want to breastfeed. And so that's fabulous that we have the two of them and that we're able to help support moms in this. And then through Ryan White funding, we receive parts A, B, and D. We're able to see patients who are uninsured as well. So we provide primary and adolescent care. We provide gender affirming care, mental health services, medical and non-medical case management, emergency financial assistance, which I'll refer to as EFA, transition planning and execution. So to help patients transition to adult care, mother-baby care, breastfeeding support, PrEP and rapid HIV testing, and then coordinated care as well for youth who are adopted and are living with HIV. So this slide kind of highlights the differences, the different services we provide, like medical case management. So we do a lot of individualized treatment adherence plans for patients. We monitor very closely our patients who haven't been seen or engaged in care in over 2 months. We help patients with referrals and help coordinate their care. And then we do lots of health education and programming. And then non-medical case management, like I mentioned, we do transitioning patients to adult services. We connect patients to adult disability needs and resources as they need them. Miss Jackie, our non-medical case manager, is fabulous at connecting patients to dental and vision care through the Wilmer Institute here at Hopkins and then the University of Maryland School of Dentistry. They have a Ryan White funded program and are able to see our patients. And then Ms. Jackie does a lot of advocacy for IEP services as well. So making sure that our patients who have an IEP are getting the services that they are supposed to be getting through that. And then we do a lot to connect patients to community resources. So making sure patients are getting their SNAP benefits, connecting them and assisting them with the unemployment process, insurance renewals, housing, anything that comes up for our patients, we try to provide wraparound services to get them what they need. And then we also have a fabulous integrated mental health team. So Jamie Margolis is our IPC mental health coordinator, and then Anna is our psychiatric mental health NP. And the two of them, Jamie is on site 5 days a week, and Anna is able to see patients twice a week. And this really helps us when we have patients who are struggling with acute mental health needs. They're able to get connected to care immediately and see someone, which is an amazing resource to have. They provide goal-oriented, data-driven care. And then they also they provide on-site therapy for patients and connect patients to resources in the community. If there's a certain type of therapist they would rather see who deals with a particular issue, Jamie and Anna are able to help facilitate those referrals. So this gets into the age breakdown of our youth, and just to share some data about our clinic. So in 2020, we had 102 HIV positive youth who were seen for 315 medical visits. This doesn't include mental health visits or case management visits. So we were really definitely busy throughout 2020 and throughout the pandemic. We had 25 HIV exposed infants who were seen for 135 medical visits. And then Marianne also saw mother and baby pairs as well. So of our 102 youth who are living with HIV, this data doesn't include HIV exposed infants. 19% of our patients are under the age of 13. And then 35% of our patients fall between the 13 to 20 years old. And then 46% of our patients are 21 to 26. So that's definitely the biggest percentage of our patient population. This data here shows the gender breakdown of our patients and then exposure category. So 47% of our patients are male, 49% are female, and then 4% are trans female. For the exposure category here, the largest percentage of our exposure category are 52.9% acquired HIV through perinatal transmission, 33.3% acquired HIV through male-to-male sexual contact, and then 11.8% acquired HIV through heterosexual sexual contact. And then this is always interesting to people when I present, but 2% of our patient population acquired HIV through blood transfusions, which you don't hear about as often here in the US anymore. And those youth were born elsewhere and are now in care here in Maryland, in Baltimore at the IPC clinic. For viral suppression data, so this looks at March of 2020 to February of 2021. During that time, of our 102 patients, we had 91 patients who came in to have viral loads drawn. 77 of those 91 clients had viral loads under 200, which makes a viral suppression rate of 85%. When you look at our total number of patients, 102 patients, this is a viral suppression rate of 75%, which was a drop for us and is going to lead me to talk about some of the QI initiatives that we came up with to address this. And then the Baltimore City data that I have, I won't really get into because the 2020 data isn't available yet. So it's hard to, you can't compare 2020 to any other year. And so I'm going to talk about our IPC 2020 data. And once the 2020 city and state data is out there for 2020, it'll be interesting to compare and see the numbers and see if other clinics were having the same struggles that we were. So this leads me to talk about QI, or quality improvement. So the definition from HRSA is QI consists of systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of a targeted group. So for us, the measurable improvement in healthcare services that we're really focused on are looking for changes to systems that improve viral load suppression. And then our targeted group are infants, children, youth, young adults living with HIV. So the 4 key principles for a successful QI program, according to HRSA, are QI work as systems and processes, a focus on patients, a focus on being part of the team, and then a focus on the use of data. So this picture here was taken in 2019. It's a pre-pandemic photo, but this shows a picture of our Tuesday staff meetings. So every Tuesday, our whole team gets together, which includes our IPC clinic staff, our Part D staff, our mental health team, and our research teams to discuss patient care and health outcomes. So we really look at the data. We look at patient lab values. We look at things like our no-show rate. And we really have these intense focused discussions as a group to look for areas where we're lacking in efficiency and looking for different areas where we can improve. So we're able to make lots of suggestions here in these meetings and come up with ideas. And this is really where a lot of our QI projects kind of start. So as I mentioned earlier, we're not experts in QI. There are many experts in the field. So the Ryan White program actually has a whole Center for Quality Improvement that has lots of resources available online as well. But we wanted to provide a clinical perspective of how we come up with different ideas and keep them sustainable and work things into our process, and then how we try to get that information out there. In addition to this team meeting every Tuesday, we also have a monthly meeting with the Bartlett Clinic with their ACE clinic. And then we also have a monthly mental health meeting. So those are other spaces as well where we're sharing ideas and really looking at our data to see how we can improve health outcomes and viral suppression rates. And then I wanted to give a shout out to Iris as well. Iris is our Part D case, one of our Part D case managers, and she heads the Empowering Mind Youth Advisory Board, which is our YAB here at Hopkins or here at Harriet Lane. So this is a group that's open to youth ages 13 to 24. And they have been instrumental in giving us lots of suggestions for QI projects. And then when we have ideas, we're able to present them to our youth in the YAB, and they're able to say, no, that is not youth friendly. That's not a great idea. So they have been really super important for us in coming up with these initiatives and making sure that they're successful in things that are actually patient-centered. And then I also wanted to give a shout out to our Part D case manager, Jennifer Robinson. So when we talk about things like disseminating the information and sharing what's worked well for us, I feel like Jennifer is a perfect example of this. She's involved in lots of community organizations like BTAN, the Black Treatment Advocates Network here in Baltimore City. So she's able to share with them kind of what's working for us and bring back ideas to us from the different meetings and sessions that she's attending. So we definitely appreciate all of their hard work and dedication. So looking at that viral suppression data, we noticed, this is the first project that I'll kind of highlight. 2020 was a big year for lots of rapid fire quality improvement projects. Some of them worked, some of them didn't work so well. 2020 was a big year in being flexible. So one of the ones I wanted to highlight was this drop in our viral suppression rate. So in March of 2020, COVID hit, and really, well, that's when our clinic kind of started to develop lots of new restrictions to keep patients and families and staff safe. And there were a lot of changes to clinic policy where things like walk-in visits were no longer allowed, which is something that our patients had really relied on in the past. And then there were restrictions to visit types. So it was hard to bring patients in for things like medication adherence visits, because we were really only allowing patients to come in who needed things that had to be done on site. So like STI treatment, vaccines, significant vaginal bleeding, things that required on-site assessments, those were allowed, but we were not able to get patients in for a lot of other things, which they had relied on in the past. There was a big switch to telemedicine, which was amazing because it helped keep patients safe and provides patients with a lot of flexibility. But there were definitely a lot of issues that we noticed and had to implement a lot of QI projects to help address these barriers. So during May of 2020, when we got together in our big staff meeting, we were looking at our data and noticed that patients who had telemedicine visits were not following up on their labs. And obviously labs are critical to catch medication adherence issues. So we looked at the data. We had 14 patients who had 18 telemedicine visits. 10 of those patients had labs ordered, and only 2 of those patients actually came in to get their labs. So based on this, we realized we had to come up with some sort of formalized plan or process to try to get patients, to make it easier for them to come in to get their labs done. So the interventions we came up with were a spreadsheet where we would do a weekly review of labs. We looked at who had labs ordered, who wasn't making it in, and then we logged reminder calls that we would do for patients. We offered patients the option to use outside labs and provided them with resources to get to those labs if it was easier for them, and helped them set up the appointments at those labs so that to really try to minimize the barriers so that they could get those labs done. And then we encourage patients to get labs before their visit. This was helpful because we could keep giving them reminder calls about the telemedicine visit coming up, and try to get them to get their labs in, which was great because when you have the labs for the visit, you're able to address almost more than you can if you are waiting to get the labs after the visit. And then this was one we really didn't like to do, but every once in a while it was something we would have to resort to, was withholding medication refills until labs were obtained. And there's definitely more cons to this than pros if someone's taking their medication daily. But this was something that sometimes had to be resorted to get patients to get their labs to make sure everything was going safely. So looking at this, from 102 patients, 91 patients had viral loads drawn in 2020. And so our rate dipped, but after making some improvements, we were able to encourage more telemedicine patients to come in for their labs. And another big thing that helped was we worked closely with our clinic here at Harriet Lane to advocate for things like making sure that labs were considered a walk-in visit. So that was the one visit type that was allowed as walk-in, was the lab, which helped reduce barriers for patients because there was more flexibility. So in April of 2020, we submitted a paper to the Journal of Adolescent Health. And this paper documented the rapid fire QI projects we were coming up with that we had to implement really quickly at the start of the pandemic as our institution policies were changing. We wanted to highlight so that we could share with others some of the things that we had done that were working, and then to hear from others too about what they were implementing in their clinics to address some of these new barriers. And while they were keeping people safe from COVID, there were definitely challenges we were seeing then with medication adherence and engagement in care. So the paper had a chart in it that looked at what our clinic used to do prior to COVID-19. We highlighted what the institutional change was, and then the adaptations that we came up with, and then what that impact was. So we tried to get that information out there to others. And it was broken down into 4 categories. So there were a focus on medical visits, case management, mental health, and then resources and EFA. So I won't go into each chart too much, but just to highlight a few of them. Like I said, a lot of our patients were really reliant on being able to walk into clinic. They wouldn't necessarily be able to get a provider visit if they walked in, but there would at least be someone on site who could meet with them if they were having an acute need and either triage whatever that need was or address it right there and come up with a care plan to be able to help them out. Once COVID-19 hit, no walk-ins were permitted. And so we, in those early months and weeks of COVID, we reached out to people proactively to make sure that we were sharing with them new clinic policies, which were changing regularly. So we would try to reach out to them whenever there were big shifts or changes in policy to make sure that they weren't blindsided by that. And those calls were really great because we were able to hear from patients what they were experiencing as a result of COVID. We were able to connect them to community resources. That way, we were able to hear if they were, if their families didn't have PPE and stuff like that. And that helped us develop a lot of QI projects in response to COVID as well, because we were able to hear from patients early on as we proactively reached out to them to see what kind of projects and interventions we had to put in place. Another big thing, the change to telemedicine, while it was great for some people and provided lots of flexibility and obviously safety, because there was a lack of public transportation at that time. There was a big lack of safe ways for people to travel to things like appointments. So telemedicine was great for all of that, but there were definitely a lot of health disparities with telemedicine. A big one is that a lot of our patients don't have reliable mobile technology, which is something that we've noticed pre-COVID as well. And so we applied for funding to be able to get additional phones to get out to patients, which was something that came about from a QI project we had done years ago, looking at the impact of giving patients phones and prepaid cards to be able to have minutes for the month. So I won't, for case management, it was similar issues and then similar strategies, but the big thing was making sure we were reaching out to patients proactively to hear kind of what it was that they needed and what they were facing with the onset of COVID. So advantages that we found as we did assessments of the different adaptations we came up with were the switch from in-person visits to telemedicine were things like decreases in unnecessary trips to clinic, which protects patients and staff. And then there were a lot more food resources available here in clinic and out in the community as well. And so we were able to connect people to those resources. There were more resources than we had prior to COVID. But disadvantages included limited in-person case management, which limits the way that we're able to serve people in the way that they're accustomed to and that have worked for them. There was an increased patient perception that their needs were not a priority unless it related to COVID. And then there was an increased burden because we had limited staff on site, which was definitely challenging to meet all of the patient needs. Mental health at the time, a similar situation in that we weren't able to do acute mental health need. Our patients used to be able to walk in if they were experiencing an acute mental health crisis. And a lot of those services had to be transitioned to telemedicine. So we transitioned, we tried to advocate to make sure that patients could come in if they needed to, if they were having an acute mental health need. So we opened up more templates to make space for that and advocated to make that an allowed visit type here in clinic. Advantages with mental health, I think for telemedicine, we found patients shared with us that those who were reluctant to engage in therapy before, there were many patients who really appreciated telemedicine and felt like it was a safer space for them to engage in therapy. But disadvantages, like I said, were client crises had to be managed via phone, which can make a full assessment and treatment plan really complicated. Sometimes it's really important to see patients on site and in person. You're able to pull so much from that face-to-face interaction, and some of that doesn't happen as much when you're doing a telemedicine, like acute crises intervention. So resources in EFA, same thing, patients not being able to come in. They used to be used if they were low on food or things like phones and needed phone cards, they were able to come in on site. So we had to, clinics stopped doing walk-ins, but we were able to advocate, and there were other clinics here at Harriet Lane advocating for this as well, to make things like food pickup allowable as one of the walk-in visit types. Another thing we tried was we submitted a grant to do like a mobile van to deliver essential resources to patients and deliver things like food, PPE, technology to help support them. And this grant didn't come through. We didn't get the funding to do a medical or a mobile van. But from writing up that grant, we came up with ways. We increased the amount of house visits we were doing, home visits we were doing, to be able to provide things like PPE to families and then other resources as well. So that just, I think for us, that taught us that some of the QI initiatives that don't necessarily work out or you don't get the funding to do, you can still pull ideas from that and creatively rework it into something else. So I talked a bit about emergency financial assistance and adaptations that we came up with during COVID. But all of our EFA that we give, what we've decided to prioritize has really come about through QI projects. So two that I wanted to highlight, one was our Lyft account for medical transportation. We used to use taxis a few years back, and that wasn't always the most reliable. So a few years ago, 2 years ago, we created a Lyft account to be able to get patients to and from appointments. And looking at the data, we saw that this significantly reduced our no-show rate because we had a way to provide patients with safe, reliable transportation. It's also great because we can monitor the account. So if we see someone miss their lift and it's 30, 40 minutes before their appointment, all of us here are getting on our phones to that patient, blowing up their phone, getting Iris to help blow up their phone, Jennifer, so that we can really get that patient in. So that's been really significant. And we've seen a drop in our no-show rate since implementing that. So we looked at the data, noticed we had a higher no-show rate, came up with this idea of implementing a Lyft, and then looked at the data and saw that it has improved our no-show rate and has improved our attendance rate here in clinic. And then we were able to also share that with other clinics here in our space and share that Lyft accounts have really worked well for us. So we were able to share that having a Lyft account has been really beneficial to us, and now other clinics also, not to take all the credit, not for us to take all the credit of them having these Lyft accounts, but sharing that information and sharing what works well has, I think, been helpful. And sharing what the process is for who's going to order the Lyft, how we communicate with patients, that's all been really big. And then the other one, which I talked about a little bit, is cell phone assistance. So years ago, it was noticed that our patients really don't always have reliable cell phones. They might not be able to keep up with the bill. And having that phone is super, super important because it's a way for them to connect, for patients to connect with us and engage in care. And then to engage in life, you need a phone to be able to apply for jobs and hear back from jobs and connect with your employer. So it's having a reliable phone is critical. So we did lots of QI initiatives around cell phones. And then with the advent of telemedicine, we were able to see that there were significant health disparities in who has access to care based on who has access to a phone, and how do we reduce that to help reduce that barrier. So this leads me to mechanisms for disseminating information. So like I shared with Jennifer, being a part of community programs and sharing what we're doing and bringing back to us what she's hearing in her meetings. The big takeaway is not to hoard solutions and ideas that are working. Same to share things, solutions and ideas that aren't working too, and to hear what other clinics and what other teams across the community are doing and where they're having success. So collaborating with community agencies, we collaborate with other clinics. We do lots of presentations to the emergency department. particularly around how you give a positive HIV diagnosis, what labs should be ordered if you do have a positive HIV diagnosis and that patient is still there. So disseminating quality improvement information. A really fun one that we had recently. So several years ago, the Vanderbilt Institute for Global Health came and toured the IPC clinic and heard from staff to hear what kind of services we provide. And recently, last month, we actually did a reverse site visit, and their clinic is up and running and has been running for several months, and they presented to us what they're doing. And it was a super fun meeting. We learned a lot from them in the short time that they've been open. And we were all like writing down ideas that we want to steal and take away for our patients that they've had success with, and vice versa. They were hearing from us about like different adaptations and things we've been doing. And that was really fun. And then I mentioned Jennifer on BTAN, and we have other staff who are participating on lots of different boards and in different community spaces, sharing information that we have and bringing back to us information and ideas that are working for these different organizations. One example that I'll have Dr. Agwu share a little bit about was the ARV stewardship practice. So Dr. Agwu was a part of a team that created an assessment tool to screen for issues related to genotype resistant, virologic and immunologic response, drug-to-drug interactions, side effects, and looking at ways to simplify regimens and make it easier for patients. So this team shared this information out, published papers about it, shared how this was really working for them, and it's now part of the HIV treatment guidelines. So that's an example too of ways that you can help disseminate data and things that are working to really help people everywhere. Dr. Agwu, do you have anything to add on that one?
No, and I think just important to not just highlight the things that are positive, right? When you do a self-assessment and look at quality, it's well, how you can report the things that you're not doing well either, and it's opportunities to improve that. And then you share the things that were bad and good. And I think that was the thing about this. We had to be introspective in order to improve ourselves. And then it's like, well, then how do we pass that on to other people so they can do the same? So perfect.
So that also, yeah, I wanted to highlight too, I kind of breezed over that, but different challenges that we've had with some of these QI projects. Like Dr. Agwu mentioned, we have a lot of things that work really well, but then we have a lot of things where you try something out and it doesn't work the way you expected it to, or it's too cumbersome or more time consuming than you were expecting it to be, in a way that takes you away from other sides of patient care. So that can definitely be a challenge. And so coming together in those meetings is really key, and sharing like, this is absolutely not working. I remember one of the first QI initiatives that I came up with, I brought the idea to the team. It was for moving patients through clinic more efficiently. And I came up with like a diagram chart system that I thought would be helpful. And when I brought it to the team, they really gave me lots of feedback that it wasn't patient-centered. And that was really helpful for me to then tweak and learn from and make changes to. So yeah, I think that's a really important piece of it as well. So does anyone have any questions, or I'd love to hear too what other groups have done that's been in terms of QI that's been really helpful. So I'll open it up to questions.
Great job, Megan. While people get unmuted or put text questions in the chat, one of the things that I think it's worth talking about is sustainability, right? Because we do these projects and everybody's on board. We can, or people who are in a part of the clinic can speak to sustainability and how we determine what things need to keep going, and then how to keep the energy to keep doing those things. I don't know if you have any comments about that.
If I have any?
Yep, or others.
Yeah. I think for us, one of the big things is as things are working, making sure you're building in funding where you can for the upcoming year to be able to sustain that. And then if you if you don't get all the funding that you were expecting to, or the same amount, trying to creatively then figure out ways to still keep bits and pieces of that project still going. I think that's one of the things for us, and collecting the data. I think really having the data to show that this is really helping with health outcomes, specifically with improving viral load suppression. That helps a lot when you're applying for things like grants and funding.
I think so. I think, at the end of the day, many people in here are Ryan-wide funded. And so it's always back to the HIV/AIDS Bureau, measures and what you're aiming to do. And so it's viral suppression. But as you deal with patients, you know that if they don't have a place to stay, they don't have food, they don't have those things, all will impact how they engage. And so sometimes it sounds like, oh, well, we're getting an iPad for a patient to do X, Y, and Z. And it's like, how does it relate? Well, they're able to have their doctor's appointment. They're able to do follow-up that way. And then they're also able to do their schoolwork as part of that, right? And then that helps the viral suppression. So we found ourselves really thinking through, and the YAB, like you mentioned, and just the team coming up with even one patient, if that worked for one patient anecdotally, well, who else can it work for or against? So I think that's really key. And other piece to say, empowering everybody on the team. What I love about our meetings, it's not that, well, my ideas overpower your idea. It's everybody together. And initiatives have been sparked by anybody on the team, and particularly from the patients themselves. They say, can you just do this?
Yes. Or, that's not such a great idia. The feedback is very honest, and it's helpful, and you have to be willing to be flexible and hear that feedback and and adjust.
Right, and get over your feelings. I think you highlighted the ARV initiative, and honestly, the way that came about was I had inherited a patient, and in inheriting that patient, I noticed that they were on an archaic regimen, right? And so it's like, okay, let me make that change. And then I said, well, if that patient's on that regimen, who else is? And so it literally started with me as a fellow, just, a new faculty member, actually, just pulling the list of patients coming that week and reviewing and saying, well, I saw this. And at first people were in their feelings like, oh, how dare you criticize my regimen? And before you knew it, people were like, oh, let's talk about my patient, that patient. And then it was a ripple effect, and everybody was sort of reassessing it. We should not be afraid to look at ourselves and then enhance or improve, right? We're not all doing great, right? How do we elevate ourselves? All right. Questions, comments, concerns. Great job, Megan, by the way.
Oh, thank you.
Well, I'll ask a question. I see the women's program, I see Sinai. I wonder if you'd be willing to share some of the initiatives that you've done during COVID that you have worked and also that haven't worked and some outcomes. Engage and amplify. And if you don't raise your hand, I'm going to call on you. Let's start with Jean Keller. Jean?
So I think similarly to you all, I think getting LIFT involved was key to getting, with us, because there were OB patients we saw continually through COVID, but trying to spread them out, but then bringing them in with LIFT so they didn't have to do public transportation was key. And then we found that it really improved our show rate. So it's something we really want to continue. That and I think being able to supply food cards during COVID was, there was a lot of, we really were, and it really helped us to discover just what a food shortage there is among our patients, how that really is a need that we may not have addressed adequately pre-COVID. So those things, two things I think of off the top of my head. I don't, I'll let Sinai also speak up and see if they had similar experience.
Sarah?
Yep. Hi. Yes. So we also, one of the biggest challenges was just resources in the middle of the pandemic. We had an Uber account already established. So just obviously being able to use that to get patients in was a huge resource, but also just access to food was again a huge issue during COVID. And we were able to access food cards and food banks and a lot of our staff energy went into getting food boxes and delivering them to individuals who weren't comfortable to go out in the community at that time. In addition, we really increased our support through our psychosocial support. So we did, we went from in-person meetings typically once a week for our support groups to like not being able to see anybody face to face. So in the very beginning, we went straight to weekly phone calls and just had a conference line established and just really reached out to individuals. We also were doing mass mailings of our support newsletter, as we call it. Typically, they would go out once a month with like a calendar. We came up with all sorts of just information and fun activities to keep people engaged, to remind them they're supported. And then we took all of our classes to virtual and helped individuals try to get online and participate in support activities virtually. So lots of big challenges there, but just really an immense amount of time and effort went into just reaching out to patients. Just, are you okay? You know, you've been in the house now a month, 2 months, a year. What are you doing? What can we help with? And just really making sure that the patients were reminded to reach out to us, to not isolate themselves completely, and to continue to take their medicines, to remain hopeful. And today we happen to be having, right now, our first in-person indoor group since the beginning of the pandemic. So I'm super excited. We have pulled off 2 outdoor groups previously over in the Arboretum across the street, and they were lovely, but today was way too hot. And we did get the go-ahead to resume some in-person support groups, which is huge. So,
Sarah, I actually remember Nancy told us about the newsletters and stuff that you were sending out, and we were so impressed by that. And that is an example of, we heard that you all were doing that, and that really impacted what we pulled together to send out to patients. So hearing the success you were having with that was
awesome. That's wonderful. That was, yeah, that was, whew, I'll tell you what, in the beginning of the pandemic, I was in here once a week by myself with stuffing newsletters and printing, and, you know, all the staff was coming together with just, you know, okay, let's share a recipe. Oh, let's put a crossword puzzle on the back, and just coming up with ideas. And then I'm in here stuffing them once a week. It was a big undertaking, but it was so worth it. Just to be able to maintain a regular outreach to everyone, not just the people that reach out to us. So it's exciting. So I'm glad it helped other people too.
Yeah.
I think that even that, just that connectivity is a quality improvement initiative. I mean, I think it's hard to measure isolation, fear, and the things that were going on in the pandemic, how that impacted how people then subsequently engaged. And so I think even that can be looked at as a quality improvement. It is one, right?
We did actually. I had a social work student this year, which was in and of itself a challenge. Have a student in the middle of a pandemic is something. But she actually did an isolation scale when we were doing our normal kind of satisfaction with the set of groups that just finished. We always ask, like, you know, did this help you with depression, anxiety, those kind of things? But then in addition, she did an isolation scale this time. And we found that predominantly the people who were participating, you know, again, did not feel very isolated, which I was like, it worked.
Yeah,
that was good news.
That's great.
You know, you can only measure who participates though. So I'm sure there were others out there. I'm hoping that we reach them through the newsletters and other things, but yeah, so we did make it into a mini quality improvement project.
Great. There was a couple of questions about, I think Latoya asked about funding. Luckily, I mean, I think when we're talking about the funding for people living with HIV, many of us are fortunate enough to have Ryan White funding. This past year, over the pandemic period, there were additional funds emergent needs funding, as well as COVID-related funds that we were able to tap into. And I think, to speak to, I don't see my white people on, but in terms of sustainability, though, some of those programs are not necessarily going to continue. And, recognizing, and I do hope that HRSA is going to look at this, the impact of those funds and how they then impacted people, suppression, engagement, and care. And it speaks to, if you protect people and support people, they can engage, right? And those funds are able to do that. So hopefully some of the initiatives that we have, we can feedback to say, here's how it worked for people, and they can become things that can be then included in a sustainable manner.
I also
Sorry.
think it would be so interesting to see, like, one QI project I'd be interested in is seeing if we could get even additional funding on top of that to be able to support patients to get things that aren't necessarily medical visits, but are still really important for them. So we had lots of patients who were trying to find stable employment, but didn't have a way to get to the interview safely during COVID. And even people work really far away. And so that would be an interesting project to me as well, how that impacts engagement and care.
Hi, it's Jean Keller again. So I'm thinking about what you're talking about and talking about funding and how we're going to lose some of that money that we had access to. One of the arguments we can make to HRSA, not only by showing that we had an improvement during an epidemic, is that they're really focusing now on the social determinants of health. And these are the kinds of things we were able to provide during COVID, because that extra money really addressed the social determinants of health more completely than we have been able to do in the past. And I too am struggling with how I'm going to have enough lift money for pregnant women to keep them, because it really does help them keep appointments. And we actually did one of our QI projects on that and showed a really great response and show rate by using Lyft. And can we use that data to say, listen, you need to stop cutting us and flat funding us and giving us more so we can provide those things that they need.
Good point. Megan, there's a question for you in the chat from Kayla Hearn about QI interventions requiring more staff time, and recognize how we're already busy, and how do we find the time to balance between increased responsibilities and improvements in practice, the QI and the responsibilities you already have in place. It's a really great question.
Yeah, I think that's a really good question. And I think that's something that we're still always trying to figure out and is a moving piece. I think us being able to meet weekly as that big team is really helpful, because we're able to share the process as we're going through it and help to delegate. If someone's working on this and a piece of it sparks interest in somebody else on the team, we're really able to kind of delegate it all amongst ourselves. And then I think sometimes just like getting started on a project, so sharing the idea and coming up with solutions, and sometimes just getting started is a important way to deal with some of that, because once you just get it in place, you can improve it as you go and make it part of your practice. But yeah, I think we kept those meetings going during COVID, and that was really important. We were meeting virtually, but not cutting down on those meetings was really an important part of that as well, so that we could talk through those issues that were coming up with busyness and adjusting and stuff.
Yeah, I think to add to that, Megan, the projects that we tend to be things that it's just one or two questions we may add to what we're already doing. So it kind of embeds in our workflow a little bit. And if we're doing something that requires another whole other additional piece, we'll oftentimes do it as a time limited thing. So there's a little extra thing for a period of time, and then we can say, did that work? Is that worth implementing in another way? So I think we try to do a good balance with that. We're not always perfect at that, but that tends to be the attempt. Right. Any last burning questions? Other things you want to highlight? Right. Awesome. Thank you, everybody, for your time, your attention. Great job again, Megan. Thank you for Marinas and team in the background, Iris and Jennifer and the IPC team and all the teams I see on. Again, remember, our goal is to engage and amplify. And if you heard something today and you say, well, we're doing something similar, or we are doing something completely novel, would love to share, please email us the Part D team would love to amplify your voice as well so we can learn from you. This is not us important, it's a bi-directional thing, and we really do want to hear from you as well. All right, with that, we'll stop, get some sun, your vitamin D, and we'll see you next time when Dr. Renata Arrington-Sanders will be talking about providing appropriate care for LGBTQ youth. All right, thank you, everybody.
Thank you.